Hi there, my name's Thomas Waterfield and I am a paediatric emergency medicines doctor, and today I'm going to talk to you about the assessment of young febrile infants. This talk's very much aimed at anyone that may assess a febrile infant, whether that be a general practitioner, emergency medicine doctor or paediatric specialist. So why do we need to specifically look at and consider how we approach young infants? Well, young infants are particularly at high risk of invasive and serious bacterial infection, and we know from a number of studies that in a UK type setting, in a Western Europe type setting, the rates of invasive bacterial infection in children under 3 months that present with a temperature is in around 2 to 4%. And when we talk about invasive bacterial infection, we talk about bacterial sepsis and we talk about meningitis. That 2 to 4% then doesn't include children which will have urinary tract infections, bacterial gastroenteritis, and other serious bacterial infections that would also need treating in a hospital setting. This then means that children under 3 months have a much higher rate of serious and invasive bacterial infection than older children. In addition to them being at relatively high risk for serious and invasive bacterial infection, this age group to children under 3 months are typically a little harder to assess. The clinical features of serious bacterial infection are more subtle, and the children may look relatively well until they decompensate. So how should we approach a febrile infant? Well, some of this depends a little bit on who you are and your setting and where you're working. So based on the NICE guidance, certainly if you're in general practice and a young infant under 3 months of age presents to you with a fever or a history of fever, that child should be referred to the nearest paediatric specialist, which may be in an emergency department or a paediatric assessment unit. It's important here to note that a history of fever in this age group should be taken on a par with a fever that you actually record or see yourself. There's pretty good evidence now coming out that a good report of a history of fever carries a similar risk, especially in this age group. Then if you're an emergency department, perhaps a non-paediatric emergency medicine specialist, then you've got essentially the responsibility to resuscitate and refer. And what I mean by this is that although you would be expected to refer this child on to someone with relative paediatric experience, your responsibility is a little bit more than that of a primary care physician, and you would be expected to assess the child, resuscitate them where appropriately, and this could include administering a broad spectrum antibiotic. In children who appear relatively well, you may want to refer them on fairly quickly for a paediatric assessment. And then the final part will be the paediatric specialist. This could be based in a paediatric emergency medicine department or a paediatric assessment unit. And here your responsibilities are a little bit more definitive in terms of not only resuscitating the child, administering antibiotics, but also looking at providing ongoing care and coming up with a definitive diagnosis where possible. So you're faced with a young febrile infant, and they may appear well or unwell, and it may be difficult to determine actually how well they look. You can perform your initial assessment as you would for other children. You can record your observations, but in all children under 3 months with a fever or reported fever, NICE would recommend that they undergo investigations. These investigations would include a full blood count, C-reactive protein blood culture, urinary testing for urinary tract infection, chest x-ray if there are respiratory signs, and stool culture if there's concerns about diarrhea. A significant proportion of the children that you'll see with serious infection will have an underlying urinary tract infection in this age group, and it's really important that we get as accurate diagnosis around urinary tract infections in this age group as possible, because confirmation of a urinary tract infection in this age group does commit the child to some follow-up, which will include further imaging and possibly even prophylaxis for prevention of urinary tract infections in the future. So how do we best collect this urine? Well, it depends a little bit, and we'll come to treatment and what we will do around that in a moment or two. But if a child's going to be treated there and then immediately, we need a urine sample that's collected pre-antibiotics, and we need a urine sample that's at lowest risk of contamination. So in this group, where you're going to administer antibiotics quickly, I'd recommend getting a clean sample, such as a catheter urine or a clean catch, typically from the pure practicalities of administering antibiotics quickly, it's often easier to get an in-out catheter sample. If we collect a urine sample after the administration of antibiotics, the result's far less reliable and it may provide us with a false negative. And if we rely on non-invasive techniques for collecting urine, we can have a significant delay in administering antibiotics, or we can have a contaminated urine where we get a mixed growth or growth which is a pure contaminant but leads to the child having further investigations, some of which, such as a micturating cystourethrogram, are quite invasive, and it can also commit the child to follow-up and even prophylactic antibiotics. So one of my top recommendations, if you like, for investigations in children under 3 months where you're going to give parental antibiotics is to collect as clean a urine as possible pre-antibiotics, and to consider going for an in-out catheter or even a suprapubic aspiration under ultrasound guidance in this group. In addition to collecting the urine sample, you're going to be thinking about lumbar puncture in this group, and it's a pretty low threshold. So again, NICE would recommend, and this is based on the NICE feverish illness guidelines, which we'll post a link up to, is that infants younger than a month should all undergo a lumbar puncture. And I must say, on the whole, I would follow this with the occasional exception where perhaps the child may have an intercurrent obvious bronchiolitic illness and is very, very well. But the NICE guidance would advocate that they all have a lumbar puncture, and as a rule of thumb, I would agree with this. And then, likewise, children aged between 1 and 3 months who appear unwell, NICE advocate lumbar puncture. And again, I think this is incredibly reasonable. It then also talks about children between 1 and 3 months with an abnormal white cell count. This is worth considering and bearing in mind. I'm not advocating that we do not follow NICE guidelines. I think anyone that you're giving parental antibiotics to, it's worth performing a lumbar puncture. Anyone where there's concerns about meningitis, and if they do have abnormal infection markers, then yes, I would also consider a lumbar puncture for those children. The timing of that lumbar puncture is worth considering. So we do have some time. Unlike the urine collection, it doesn't have to be done immediately before antibiotics, but the earlier it's collected, the better. So wherever possible, you would try and perform your lumbar puncture pre-antibiotics, assuming it doesn't delay the administration of the antibiotic itself. You, of course, would also ensure that the child was actually fit and stable enough to undergo the procedure, and you can find links quite easily to the indications and contraindications for lumbar puncture. But essentially, any child with sepsis who is needing fluid resuscitation would not be suitable for an immediate lumbar puncture. Anyone with a spreading petechial purpuric rash would not be suitable for lumbar puncture. Essentially, it's a little bit of common sense. It's where you have a febrile child who's concerned that there may be an underlying meningitis and they're fit and well enough to undergo the procedure pre-antibiotics. So we've talked a little bit about the investigations and in which children we're going to perform them, but what are the common infections that we see? Well, as we've already mentioned, urinary tract infections are actually a pretty significant proportion of cases. So depending on the study, it can be 1 in 4, which is what we saw in the step-by-step by Gomez. I'll post a link to that paper up alongside this podcast, up to nearly all the cases in my own study that we performed in Belfast. So urinary tract infection in this age group is a real significant cause. And we mostly see E. coli infections. Then you'll also see a significant proportion of bacterial sepsis, so febrile unwell children with confirmed blood culture or PCR for a pathogen, and that's often E. coli. You may see some group B strep, pneumococcal occasionally, but unlikely. You see Neisseria meningitidis. And this is by no means an exclusive list of all infections that you'll see. And then finally, you will see a group of children with meningitis, and again, you may see there late group B strep, E. coli, and again, pneumococcal and Neisseria meningitidis, although there are other causes. So far, it's been pretty straightforward, actually. The guidelines are pretty clear on who we need to worry about, where we need to send them, and what investigations we need to do. So what about treatment? Well, essentially all neonates, so all children under a month, are treated as particularly high risk, and this is because those children are less likely to have viral infection they're more likely to have vertically transmitted infection, they're higher risk for serious infection, and they're very hard to assess. So any child under a month with a fever should receive broad spectrum antibiotics, and in this age group it will be typically cefotaxime and amoxicillin in the UK. The third generation cephalosporin gives good CSF penetration and protects against gram negatives and gives good cover for meningitis. The amoxicillin is there to cover for listeria. The reason we go for cefotaxime over ceftriaxone is an associated risk of conjugated hyperbilirubinemia in ceftriaxone in very young infants. Children aged between 1 to 3 months of age, nice guidance, which is what this talk's based around, depending on which guidance you read, tells you to do one of two things. So if you read the nice sepsis guidelines and look at children under 5, any child under 3 months with a temperature over 38 degrees would receive antibiotics within an hour. If you read the nice feverish illness guidelines, any child between 1 to 3 months who appears unwell and has a temperature over 38 would receive immediate antibiotics. I haven't been able to resolve this issue myself between the two guidelines, but I find that I lean towards the feverish illness guideline with some discretion to choose the antibiotics for those between 1 to 3 months. Antibiotics wise, again in this age group, so typically again you'll find lots of places using cefotaxime and amoxicillin. There is some evidence that listeria is incredibly rare beyond the neonatal period, so some departments will have dropped the amoxicillin. Some places will even allow ceftriaxone over a month. But essentially, if you're not sure and you want to stick with cefotaxime and amoxicillin in a UK practice, with both of them at a 50 milligrams per kilogram dose, you will not go far wrong. So let's take a moment just to think a little bit more about those children between 1 to 3 months. So let's say we've chosen to work from the nice feverish illness guideline rather than the nice sepsis guideline, and we've given ourselves a little bit of room to essentially assess this child between 1 to 3 months. Well, should we just give them all antibiotics? Well, probably not, in that we know that although the risk is relatively high, somewhere between 2 and 4%, actually that risk is not evenly spread over all of these children. What I mean by that is that we know that children under a month are much higher risk, and we know that children appear unwell at presentation are much higher risk. So if they're over a month and they appear well, it's reasonable to consider closely monitoring them while you complete their diagnostic assessment. And what we mean by that is collecting a urine sample by the cleanest route possible, collecting a CRP, a full blood count, and the investigations as outlined, and then deciding at the end of that whether or not we want to treat or observe. So there is some evidence coming out to try and help us with this. So the step-by-step approach by Gomez, which is a multi-centred paediatric emergency medicine study of thousands of children across Europe presenting with fever without source under 3 months, looked exactly at this. And essentially they were able to show that in children that were over 21 days old, appeared well and had normal investigations including CRP, full blood count, urinalysis and procalcitonin, that they were exceptionally low risk for invasive infection, and that they were even advocating that some of these children would be suitable for discharge. Now, whilst that paper is somewhat groundbreaking, it isn't going to necessarily immediately translate into our practice in the UK, but there are some things we can learn from it. So certainly if you have a child that looks well, is over a month, with completely normal investigations, they are very, very low risk for invasive infection, and they may be suitable for an extended period of observation rather than giving antibiotics just in case. So this is something that myself and my colleagues in Belfast had a bit of an interest in. Essentially, how can we decide safely who to give antibiotics to? Where can we use our judgment? And how can we use the learning from work like Step by Step in our practice safely in the UK? And so we actually trialled point of care procalcitonin as a test for these children in the emergency department. And on the screen you'll be able to see our guideline and our approach. So First thing we said was if the child meets the criteria for parental antibiotics as set out by NICE, then they would be treated. And what we said for that was any child under a month with a fever or history of fever of 38 or higher, we would treat. And then we said, well, actually, if they're 1 to 3 months with a fever or history of fever and look unwell, we should also treat them. But we said, actually, if they don't meet those features, and we had 38 that did, and of those, 3 had invasive infection and 8 had non-invasive serious infections. So very high rates, 11 out of 38 were treated. We said, actually, if they don't meet those immediate criteria, rather than giving antibiotics anyway, we'll perform a point-of-care procalcitonin test. So we collected 0.5 mils of blood and performed the test on the Samsung IV10 in the emergency department with results in 20 minutes. And what we said was, based on the step-by-step data, procalcitonin 0.5 seemed to show a good accuracy for detecting invasive and serious infections in this group. So we said if it's over 0.5, they're also deemed high risk. So this is an additional safety layer, if you like, in addition to NICE guidance. And we would treat them. And we had 5 children in this group that had an elevated procalcitonin despite appearing well and not meeting immediate antibiotic criteria. And of those, there were 1 invasive infection and 2 non-invasive. So again, elevated procalcitonin, significant risk of infection in this group. And one of the invasive infections was quite a nasty E. coli bacteremia, and the child did initially look well and was over a month, so it was picked up by the point of care biomarker. But we said if the procalcitonin was normal, they looked well, they're between 1 and 3 months, we'd observe them actively in the emergency department and complete essentially a diagnostic workup as per NICE, which would include a sterile urine collection, full blood count CRP, and we would review them with the results of those and make a further decision with treatment. So this guidance was very much around the emergency assessment of children. It's not their full journey of care, if you like. It's essentially looking at how we can safely make decisions in that first hour or two that are evidence-based, that allow us to make informed choices about whether or not we give parental antibiotics. So, in summary, children under 3 months with a temperature are high risk. If you're non-paediatric specialist, either in general practice or the emergency department, you should be phoning a friend. And if you are in an emergency department looking at resuscitating those children that are unwell, providing parental antibiotics and getting support as quickly as possible. If you are a paediatric specialist and you're going to follow the NICE guidelines, there will be some debate locally as to whether you follow the sepsis guidelines, the feverish illness guidelines, or a combination of the two. But my preference would be to follow the feverish illness guidelines. Any child under a month you're going to give antibiotics to, and they're typically going to be amoxicillin and cefotaxime, but may vary depending on where you work. You'll perform a diagnostic workup and you'll try and collect as clean a urine as quickly as you can, and ideally pre-antibiotics. You may or may not decide to treat every febrile child under 3 months with parental antibiotics. You may choose to look at this age group between 1 and 3 months and say that the children that look well, as long as you're actively monitoring them, it may be safe to collect the workup and then reassess them. And you may also want to consider looking at ways of getting biomarkers quickly. So although we looked at procalcitonin, what we found, and again I'll post a link to the study, was that actually CRP performed equally well in this group, and we found a CRP cutoff of 20 worked similarly to a procalcitonin cutoff of 0.5. So CRP of 20 milligrams per litre had a 93% sensitivity for excluding all bacterial infections and 100% sensitivity for excluding invasive bacterial infections. So again, if there is a way of getting CRP results quickly within your department, or to look at point of care CRP, that's somewhere in the future that may help with this group. So thank you very much for listening to this podcast. I will post links to the Gomez step-by-step paper, our BMC Pediatrics paper relating to our experience of procalcitonin in this age group in Belfast, and links to the NICE guidelines for sepsis and feverish illness in children under 5. Thank you.